And I would like to introduce Chris Lloyd from the United Kingdom. He is a pediatric ophthalmologist in London, and he will talk about pediatric cataracts, the role of genetics, and I think that's something we will hear about more and more. And I'm really delighted that Chris can present this presentation, although he will not be able to take part of the discussion, which we will have exactly after this presentation. And let's hear it from Chris.
Thank you very much. My name is Chris Lloyd. I'm a consultant pediatric ophthalmologist at Great Ormond Street Hospital. I also have an academic affiliation to Manchester University as well, where I worked for many years. My remit today is to talk about pediatric and congenital cataract and the role of new diagnostic techniques in making a precise diagnosis in these children. I have no financial disclosures to disclose. So, is cataract really a diagnosis? My response to this, of course, is no. And I'm going to talk today about what systemic disorders are most often associated, what pre- and post-operative tests should routinely be performed, and what is the role of genetics and genetic testing in 2022. And the bottom two images here illustrate how important and how helpful genetic testing can be. This was an infant who presented to us with quite marked ocular malformation. You can see there are bilateral uveal collobomas. There is cataract formation, shallowing of the anterior chamber with obliteration of the anterior chamber centrally, PFV, cataract, and a large stalk extending from the PFV malformation to the retina in the right eye. Now, we didn't know what that diagnosis was, but genetic testing identified mutations in the RARB, or retinoic acid receptor beta gene. This is an important transcriptional gene, which we were able to identify using modern techniques and thereby provide a precise diagnosis for the family. What's the epidemiology of congenital cataract? Well, the work that was done by my colleague, Professor Jugnu Rahi, with the British Congenital Cataract Interest Group indicated the incidence, certainly in the UK and Ireland, is around 2.5 per 10,000 by the age of 1. And this is similar to other studies that have been carried out in the developed world. The incidence is higher in the developing world because of infection, perinatal, or rather prenatal infection and environmental causes. This incidence increases by the age of 5 to around 3, and a little bit higher by the age of 15, again relating to developmental and environmental causes. We know that around 3/4 of pediatric and congenital cataracts are non-syndromic. When I was a fellow in the 1990s, I was tasked with producing a care pathway for children presenting to our clinic with congenital cataracts, and this is what I came up with. And it sort of works, but it's a bit clumsy and clunky. So when a child presents, you examine them, take a careful history, confirm that the diagnosis is correct, examine the parents and relatives, check to see if they're dysmorphic, look for neurodevelopmental problems and systemic disease. And obviously, as an ophthalmologist, you may not be expert at that, and so you involve your pediatric colleagues. Metabolic investigations may be required, genetic testing, which certainly back in the 90s and early 2000s involved guessing what was most likely and doing individual gene testing. Karyotyping is important, looking for gene deletions or large chromosomal deletions rather. And then once that diagnosis is confirmed, carefully assess for other associated structural abnormalities and then carry out the appropriate surgery if indicated. So this is a long-winded and challenging pathway which involves lots of different services, and which at the end of the day was not very effective. The diagnosis was delayed, and in most cases we didn't get an answer. And we carried out a study in Manchester about 6 years ago, 7 years ago. We looked at 29 successive infants presenting with bilateral cataract, tested using the traditional testing pathway, and showed that in only one was an abnormality identified, a gene deletion, and that was not necessarily the underlying cause of the cataracts. So there must be a better way, and we have now moved on to more precise diagnostic testing, which I'll talk about. What are the systemic disorders that you want to seriously consider? Well, I've listed them here, and I'm not going to talk about all of them. I'll mention a few. These make up around a quarter of the cases presenting to you in Western Europe. But there may be a different balance if you're working in different parts of the world. This list is not remotely comprehensive. It just mentions some of the important ones, or most of the important ones. Crystalline gene mutations account for 50% of pediatric cataracts. Crystallines are important structural proteins, some of which also have a chaperoning property. In other words, they're important for protein folding and conformation. The majority of crystalline mutations are dominant missense variants, and there are 13 crystalline genes expressed in the human lens. 12 are associated with cataract, and I've listed them there. CRYAB is the only one expressed outside the lens, and this mutations in this gene can be associated with cardiomyopathy and myofibrillar myopathy, as in this little boy here. So it's important to make a diagnosis because these children can become very unwell, and this young boy spent a lot of time on the intensive care unit. Low syndrome, which is due to mutations in the X-linked gene OCLR1, predominantly affects male infants. They present with these irregular dense cataracts. They may develop glaucoma, and there are important maternal carrier lens signs, which you can see on the lower images here. Typically, they develop peripheral cortical flex, but there may be posterior subcapsular opacities as well. Renal disease and neurodevelopmental delay are the important systemic features, and these children are also prone to early onset and severe epilepsy. Oculofacial cardiodental syndrome is another X-linked dominant disorder, and it causes ocular, craniofacial, cardiac, and dental abnormalities. Again, mostly in females. It tends to be a fatal disorder in male infants. The gene which underpins it, BCOR or BCOR, encodes a repressor protein which acts on the gene BCL6. And this is really important in early ocular formation and in the formation of other organs. In females, because there are 2 X chromosomes and lionization occurs, there are very variable phenotypic changes. The cataracts may be very asymmetric or appear to be unilateral. However, most affected females have significant cataracts and a degree of microphthalmia. We know that comprehensive testing is now available across the developed world using advanced sequencing technology, and we can now screen all known cataract genes simultaneously. And I was privileged enough to be involved in the group led by Graham Black in Manchester that published the work demonstrating this. And these tests have been validated, they're sensitive, accurate, and reproducible. What's the pickup rate like? Well, when you look at how appalling the pickup rate was in the past, we're now approaching 60%. So of those that are solved, around 6% have a metabolic disorder. And this is important, and I'll come on to talk about that. 21% in the Manchester group between 2013 and 2018 had syndromic cataract. In other words, there were other problems associated with the cataract. And as previously thought, around 3/4 were non-syndromic. Of those cases that were solved, of the sporadic ones, you can see that the majority are de novo mutations in known cataract genes, but a smaller proportion were due to compound heterozygous mutations. And the genetic etiology, again, as previously thought, the majority are due to autosomal dominant genes, but also a significant number with recessive and X-linked disorders. And the isolated cataract is caused predominantly by dominant missense variants, and the mechanisms, the underlying genetic mechanisms, are demonstrated in this pie chart here. There are other mechanisms, including splice altering and nonsense mutations. And I've listed here the non-syndromic genes which are associated with cataract. And obviously this is a busy slide, but it gives you an indication that most of them are dominant and that they're made up largely of crystalline and connexin mutations, but there are others which are very important. And it's interesting, now that we do genetic testing as a routine investigation, we are identifying more and more of these genes. One of the messages I want to get across is that metabolic disease is very important, and it's an important diagnosis to make because we can change children's lives. It was previously assumed to be rare and of low relevance, rarely reported and poorly described, but early diagnosis is very important because treatments are available. And here, this family demonstrates why this is so important. These are 3 young men who presented early in childhood with cataracts and mild learning difficulties. They were found to have a mutation in the gene, homozygous mutations in the gene CYP27A1. This codes for a condition known as cerebrotendinous xanthomatosis. This is a condition where there is abnormal fatty acid metabolism, and it's treatable. You can treat it with chain-O-deoxycholic acid and statins. If you don't treat it early, these individuals suffer from premature atherosclerosis, peripheral neuropathy, and neuropsychiatric problems, and they often die from heart disease in their 30s and 40s. They also develop tendon xanthomas, which are less serious, but which is what gives the condition its name. If this diagnosis is made early, the life course of these children is altered forever, assuming they get the appropriate treatment. So this is the diagnostic pipeline, which we now use routinely. When a cataract or lens abnormality is identified, a sample is taken, and we now take a sample from both parents as well. So we do trio testing. The sample is prepared and sequenced, bioinformatics are carried out, analysis and variant interpretation is performed. And then there is a multidisciplinary team meeting, including the lab-based technicians, the geneticists, and the ophthalmologists, and the genetic counselors. A clinical decision is made, a report issued, and the result is delivered to the family. And appropriate treatment is then, and long-term management is put in place. However, we don't get it right always, and there is a non-diagnostic rate, and this relates to the fact that we don't know all of the genes yet, and also that the sequencing techniques are not absolutely perfect. So more work is needed. But I would emphasize that modern genomics has transformed our way of approaching children with cataract, and cataract is not a diagnosis. Thank you very much.